we have three pillars for diagnosis. We have light microscopy, we have electron microscopy. Okay, so uh, we have immunofluorescence, light microscopy, as well as we have electron microscopy. So there are three pillars of diagnosis. With the help of these three, we are diagnosing different diseases in the histopathology. Today, I will be discussing the different stains and their clinical importance and the significance that is necessary for a nephrologist to know, and he can interpret the biopsy reports more easily and the more in a convenient way. So first of all, in nephrology, you know that in light microscopy, we are using it to check the glomeruli itself, tubules, the interstitium, the blood vessels, the cellularity, the crescents, the necrosis, the sclerosis, the glomerular basement thickness, mesangial expansion, endocapillary proliferation, as well as exocapillary proliferation of the crescents. So, in a routine, we are doing these following stains that can be hemotoxylin and eosin stain that is used for all the histopathology in the world because it is a basic stain that is used to highlight the different structures. And then we have PAS stain that is usually magenta color. And then we have Jones silver stain and then the Mason trichome stain. So these are the most usual stain that we are using in everyday for the histopathology and diagnosis. And later you can see the different immunofluorescence, and then you are seeing the electron microscopy picture at the last level. So this is actually the first picture. You can see the H and E. So it is a basic stain. It is H and E stain, that is a hemotoxylin and eosinophil stain. And the magenta color you are seeing, it is the periodic acid shift stain. And again, you can see the silver stain and the Mason trichome stain. So you should be okay. We can see the different structure. Hemotoxylin stain, the nuclei appear blue or purple, and eosin is the cytoplasm or the protein looks pink. So there are actually two dyes being used here. One dye is actually for the cytoplasm, and other is highlighting the nuclei. In a
السلام عليكم. السلام.
okay, the internet become disrupted, so I am again showing you the different slides. So I hope you will be understanding. Just a minute. So I am just again uploading the pictures for you. Okay, so this is actually the basic slide in which hemotoxylin and E-stain. So I will be showing just again. You can see this is actually there are different type of stain. So on the leftmost corner, it is a H and E stain, and nuclei are appearing purple, and eosin is actually for the red cytoplasm. Okay, so here it is the magenta color on the topmost. So this stain is actually periodic acid shift stain, and you can see the right top, that is actually silver stain that usually looks a little bit blackish. Okay. Then is immunofluorescence. It can be in case of minimal, or there can be and stain. So uh, for it is
सर आपकी आवाज ब्रेक हो रही है बार बार।
mesangium, uh, the s- the space between two connection last. Are you listening?
Yes, now we are listening.
Okay,
Now
okay,
we are
Dr. Akil. Okay, so okay, mesangium, it contains tuft of capillaries, and the space that is between the two capillaries is actually interstitium. Sorry, mesangium. So here, mesangium are the sportive tissues, and you know that there are four typical mesangial diseases in glomerulonephritis. IgM nephropathy is a mesangial disease. Similarly, C1q nephropathy is a mesangial disease. IgM nephropathy is a mesangial disease, as well as diabetes mellitus is a some sort of mesangial disease in which we will see the different diseases. So I am just talking about the first basic lecture today. Okay, so going to the next slide for you. Okay, which is this stain? Can anybody tell me the name of this stain?
PS.
This is a
best.
Yes,
PS.
it is a, yes, it is a PS periodic acid shift stain. So it is showing the magenta color. So you can again see it. This is the most important stain in a nephropathology. If examiner will ask me which stain you love in nephrology, my answer will be the periodic acid shifts again because it has a beautiful magenta color and it will highlight the carbohydrate rich structure, and you all are aware that any basement membrane is made up of
Yes, yes.
uh, carbohydrates as well as the proteins. So it highlights the GPM very beautifully, mesangial matrix and the tubule and proximal tubule brush butter. So virtually any structure looks very beautiful in a magenta or pink purple color in case of periodic acid shifts again. So if I will be calling that CT with contrast or MRI with contrast, so it is actually H and E stain with the contrast. So just this is just a simple rule. If you are highlighting any structure, almost all the structures, that is a GPM, that is a TBM, that is the mesangium, that is the capillary loops, the single best stain I personally love is the this H and E stain. Okay, ये कौन सा stain है भाई?
Trichrome.
हाँ,
Trichrome stain.
trichrome है.
Right.
Platform.
Yes, Shabash.
Trichrome.
Doctor, thank you. This is the methenamine
Silver.
silver stain. Actually,
हाँ.
in the silver
Silver
stain,
stain.
you can see that the GBM appear black. So you should be very careful. You are checking the gloom because the gloom is capillaries and the gloom are black. So it is again Jones methenamine silver stain. Okay, so again it is a picture. Again, the glomerular capillaries are looking blackish. So it is the silver stain for you people. Okay, it is again silver stain.
Silver stain is the
So
best for the membrane. It's showing membrane.
yes, it is showing
Okay.
membrane very beautifully. You are right. You are right.
Right.
So especially in case of any disease that is affecting the membrane, like membranous nephropathy, that is showing the thickness of basement membrane, or any MPGN pattern in which there is a tram track appearance. This is a very beautiful like stain that is actually highlighting the basement membrane very beautifully. Okay, so ये कौन सा stain है? So here you are seeing that glomerulosclerosis and the vascular sclerosis as well as tubulointerstitial fibrosis. So actually I was just highlighting different type of stains here. So it is again ये कौन सी stain है अभी किसी को पता है?
Sulfur stain.
Silver stain. Thank you. So ये देखो, this is actually Mason trichome stain. Okay. So in Mason trichome stain, actually it is highlighting either fibrosis or vascular halinosis. So for
Has three color.
yes,
Trichome
doctor.
has three color.
Yes, Mason
Trichome for
trichome has
fibrosis mainly. To show fibrosis by green color. Okay.
very nice. Yes, thank you. So Mason
And also
trichome stain, you are very right
yes,
that in Mason trichome stain, collagen usually when it is fibrosed, it is showing the this blue color actually. So it can show the interstitial fibrosis and glomerulosclerosis and the chronicity and fibrotic scar. So any patient that has virtually CKD due to any reason, that can be nephrotic syndrome, that can be nephritic syndrome, that can be any interstitial disease that is actually causing the advanced renal disease, will show the picture like the same here. You are seeing the fibrotic area that is appearing blue. So doctor is telling very right, brother. Thank you for helping me in my lecture, and you are putting wonderful efforts here. So it is again which stain? So it is again showing the this blue area of fibrosis and sclerosis. Yes, it is a Mason trichome stain. Actually, this is again a slide of Mason trichome stone. Here again you can see the Mason trichome. So this is actually what slide that is usually being asked in case of amyloidosis and old age patient, that can be AL amyloidosis, AA amyloidosis. So it is actually a stain of Congo red. So Congo red appear, you know that it appears like apple green bare fringes on the polarized light.
yes,
So if you are putting the polarized light, you can see the apple green bare fringes. So next is the slide of the Congo red. So here it is again Congo red. Yes. Apple
Congo red
green bare
can be used
fringes.
after showing in light microscope has a nodular changes. After
Okay,
showing
very,
nodular
very nice.
changes, I go to the Congo stain to show is it amyloid or not amyloid. Okay?
Okay, Doctor, thank you. So apple green bare fringes under the polarized light. So there can be, in case of amyloidosis, you know, there can be enlarged kidney and history of proteinuria and any history of chronic disease like familial Mediterranean fever or chronic tuberculosis or rheumatoid arthritis or IBD. So these patients will be showing cargo red and apple green for the renal amyloidosis. Okay, thank you. So here again, I am showing you in a different contrast. So you can see the periodic acid shifts again with the magenta color, and you can see the Congo red with the this appearance, and other is the silver stain. So what is this picture again? Congo red.
Congo red,
Okay.
depolarize and depolarize.
Yeah. So first one is the H&E stain, but when you
So
pick,
am I asking you about the difference between the polarized light or immunohistochemistry? Is it superior under polarized light rather than ICT, immunohistochemistry?
yes, Dr. Akhil, what is brother is asking?
I'm asking about Congo red, asking about the Congo red. Is it
Okay, so
the brother is asking about the Congo red stain. What is the difference between the apple fringes and simple Congo red you are asking about?
Yes. This is a question.
Brother, actually, if Congo red is stain. Actually, that is stain that we apply on the microscopy slide, and it appears like a Congo red. But polarized light is a different type of lamp that is being thrown on that slide, and slide show a different color. So yes, so actually that is a light, some sort of light.
Okay. Thank you.
Oh, thank you, brother. Welcome. So here you can see the Mason trichome stain that is showing the areas of halinosis and sclerosis, and the silver stain that is showing the black membranes. Thank you. So again, H&E stain that is not too much brighter, but PAS stain that is showing a magenta color, and silver stain that is showing black areas, and trichome staining that is showing areas of sclerosis and halinosis. Again, so Again, you can see the different type of stains here. So next I will be showing you the different slides. Okay, so usually we cannot diagnose a disease without the immunofluorescence, because you know that sometimes IgA nephropathy has no lesion on the simple microscopy. But when we do the immunofluorescence study, we find IgA deposits in the mesenterium. So the deposits in the mesenterium can be either linear or granular. So gradually we will be learning each other. So if it is written IgA, so are complete circles of glomerular capillaries. So it is a mesenteric, and so it is one side of IgA nephropathy. Here you can see the difference between linear and granular.
Please,
Whenever there
I
are
have
granular deposits, you can see.
mm,
So in granular diseases, you can see the small dots that are making a pattern. But in linear diseases, there is a complete line. So you can see here there is a complete line available. So these linear deposits, these occur in a whole nephrology in 5 places. These linear deposits can be present. Linear, Chacha. Linear deposits can be there in 5 days, like the Port syndrome after the kidney transplant, and the cadaveric transplant, the fibrillary GN, the diabetes mellitus, and SLE in rare cases. Dr. Akil, so can you tell me the linear deposits in whole nephrology?
The linear deposits can occur in a
Yes, doctor.
post.
Dr. Akil.
Are you hearing me?
Yes, please.
Linear deposits occur in a post-transplant patients in a cadaveric transplant, in patients with diabetes, in patients with anti-GBM disease, and patients with fibrillary GN, and also rarely in lupus nephritis.
Lupus, as well as in light chain deposition disease, there are linear
And
deposits. Okay.
light chain deposition also. Okay.
Okay, okay. So whenever they give you this type of immunofluorescence, you should be checking the history, and you should be putting the diagnosis in one of above said diagnosis. So it is a type of granular deposits. You can see the granules. So there can be fine granules if they are very delicate and very small. Like gold work. Gold work is very delicate. When the granular deposits are fine, actually that can be a different disease. And when the granular deposits are coarse, that can be a different disease. So one doctor from the Arabian countries, sir, can you tell me that what are the type of deposits in membranous nephropathy?
I'm asking me.
Yes, 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 Muhammad brother.
Okay. These are granular depositions. We show can be present with post-infectious glomerulonephritis. Also, can we give
In
it?
post-infectious glomerulonephritis, there are usually subepithelial humps as well as star-sky appearance. So I am telling,
Yes.
I am asking Dr. Sarah, can you tell me in membranous nephropathy,
Lower.
either there are fine granular deposits or coarse granular deposits?
Yes,
Yes,
lupus
Dr.
nephritis
Sarah.
possible. Lupus nephritis.
Hey,
The
Dr. Sarah.
fine granular deposition of IgG along the
Fine
capillary loops.
Fine granular deposits are any of IgG4 in a membranous nephropathy, but there are coarse granular deposits of IgG4 in fibrillary GN. Fibrillary
Fibrillary,
GN
yes,
is
sir.
associated with the hepatitis C as
Yes,
well as
yes, yeah.
HIV.
FCN HIV.
Okay. Okay, so when they give a question actually in an exam, they give sometime both things. So they can give the histopathology and they can give you the immunofluorescence. So here you can see that IgA and the C3 deposits and the C1q is present, along with the, there are deposits, the endocapillary proliferation as well. So C3 deposits along with the IgA and C1q deposits. So which disease can be? It can be IgA nephropathy. It can be
MPGN.
post-streptococcal GN. MPGN as well. Very nice. So it can be MPGN as well. Thank you very
Yes,
much.
MPGN.
So sometimes there is a full house pattern in which you can see the IgA is dominant, IgG is dominant, IgM is present, and the C3, C1q, kappa, and lambda are present. So what is the disease that presents with the full house?
Lupus.
Lupus nephritis is one of them. And other
Full
disease,
house.
can anybody?
Cryo. It can also present with HIV. HIV also presents with
Yes,
the
Dr.
full house.
Sarah, I am agreed with HIV. So HIV is sometimes called as so-called as full house, and usually the lupus is a disease that present with the full house. Thank you. So again, here you can see IgG is present, IgA is present, C3 and C1q and kappa are present. So which disease can it be? Lambda is also present. So it is again full house. Okay.
This is going with lupus.
Yes, brother.
IgG, IgM, IgA, C1q, C3
And
is going with lupus.
kappa and lambda. It can be full. Yes, it can be lupus nephritis. So actually now I am coming to the advanced lecture a little bit. So I am showing the different diseases, and now I will be asking questions about the diseases. So anybody can tell me the finding in this globe, and anybody can tell me what is the disease in this patient. Tentative possible diagnosis. So this is a normal glomerulus. Okay.
This is capillary is patent. Capillary
Yes,
is patent.
capillary lumen are patent, and there is a no endocapillary or extra capillary deposits.
This is normal. This is the normal glomeruli.
Yes, it is a normal glomeruli. So there are six differential diagnoses of normal glomerulus. So normal glomerulus can be in the minimal change disease. It can
Minimal
be
change, IgM,
it can be yes, it can be early membranous nephropathy. Yes, it can be IgA nephropathy. It can be thin basement membrane. It can be Alport syndrome. It can be lupus class 1 and 2. And it can be FSGS with the missed biopsy core.
Yes, superficial. Yes, okay.
It can be early diabetic nephropathy. Hello?
Recall these findings, the differential diagnosis of not listening me. ये स्टेन कौन सा है भाई?
सर अच्छा नहीं, cellularity ज्यादा आ रही है.
You are right. So it is H&E stain, and it is showing the normal gloom. So इसमें क्या क्या आपको? What are the DD of normal glomerulus?
Minimal change disease, FSGS with missed core, early membranous nephropathy.
Then IgA nephropathy, then basement membrane.
IgA nephropathy, lupus class 1 and 2.
Syndrome. Shabash, very nice, very nice.
IgA can present with normal glomeruli, unlikely.
Early diabetic nephropathy can also show normal light microscopic. Huh?
Yes, early diseases are usually the same.
Oh, okay.
Minimal IgM, C1q, lupus class 1. This is main differential.
Okay, lupus class 1. And the thin basement membrane and Alport syndrome.
Yes.
Okay. So here it is the electron microscopy. This blackish area, it is actually RBC that is within the capillary lumen. So you are seeing this is actually divided into 3 parts. So actually I want to put color here. This is actually the endothelium of capillary, and this one is the basement membrane, glomerular basement membrane, and these are the podocytes. So I hope you are seeing all the 3 colors. So the outer one is the podocyte. This middle one, all this going is the basement membrane, and the inner area is the capillary endothelium. So glomerular basement membrane is actually a function of 3 things. It is the capillary endothelium, it is the basement membrane, and the slit diaphragm between the podocytes. Okay. So here you can see there is This area 1 is the basement, area 2 is the podocytes, and area 3 is the caproendothelium. So if you see the podocytes, these podocytes are effaced here. So what are the differential diagnosis of the effacement of podocytes?
FSGS.
Very nice, FSGS.
It
Minimal
also
change.
membranous
Minimal
fading
change
is
disease and the membranous nephropathy. Yes. So these all are called as
And
podocytopathy.
lupus podocytopathy.
Lupus podocytopathy. Very, very nice differential, brother. Thank you very much. So there are two diseases. One is the silent lupus, and other is the lupus podocytopathy. These are not included in the 6 classes of lupus nephropathy usually, but they are the diseases that can be associated with the lupus. Okay. So it is again electron microscopy that is showing the complete effacement of podocytes. You can see this area, especially this outer area, you cannot see the podocytes here. Okay. So podocytes are effaced. Okay.
Yes,
Thank you, Dr.
clear.
Saab, Dr. Mohammed. So next, this again, whenever they give you electron microscopy, you should be seeing the three things. You should be seeing the basement membrane. That is, this is going basement membrane. So you know that normal diameter of basement membrane is 280 to 450 roughly. So it goes to the 600 in
200.
case of basement membranous nephropathy, and it goes to the 800 in case of especially diabetes. Yes, thank you, Dr. Sarabhay. So whenever they give you this electron microscopy, you should be careful for seeing the podocyte. Here you can see the effacement of podocyte, especially this yellow area I am highlighting. These are the podocytes. So yes.
Dr. Keswar, the G thickening is more in membranous as compared to diabetic kidney disease. In membranous
No.
nephropathy, I
I
have read
don't
that
agree.
15 days ago. Okay, I will check it again. Okay, sure.
Yes, I
Then
don't
I will.
agree. So actually, basement membrane it goes to the 800 in a diabetes, but it is usually 500 to 600 in a membranous nephropathy.
Okay.
Okay, so if I am wrong, so please.
What's wrong here?
I have read. I have read in the AI that the GBM thickening is more than 1100 nanometer in membranous nephropathy, and it is around 500 to 600 in diabetic kidney disease. So I
But
will check it again.
I
Okay.
think it is a vice versa, so you should check from the book. Okay. So coming to this slide, so ये कौन सा which strain it is?
PAS.
Very nice. It is a PAS strain with a magenta color. So what it is showing actually?
The segmental sclerosed area.
Very nice, brother. So it is actually showing area of segmental sclerosis. So remember, when they gave you a single gloom, always you should keep the terminology of segmental versus global. And when they gave you
भाई
8 to 10
segmental
gloom,
जो
then the
H strain पे नहीं
terminology is
आता.
no. When they gave you number of 8 to 10 gloom, then the terminology is either focal, either diffuse. So if the less than 50% gloom are involved, it is always focal disease. And when there are more than 50% gloom involved, it is a diffuse disease. But remember the mnemonic SSG. You know that Pakistan has Special Services Group Commando, SSG. So whenever the terminology is S for segmental, G for global, use a single gloom. So SSG for single gloom, always terminology is segmental versus global. So here it is a segmental problem. Brother Muhammad is telling very right. So which disease it is?
FSGS.
Going with FSGS.
Yes, it is FSGS. It is FSGS.
FSGS.
Yes, it is a segmental lesion. So can you tell me the secondary causes of FSGS? I want to mention 10 secondary causes of FSGS.
Secondary can be due to infection.
Yes, which infection? HIV, palmitoylate,
virus. It is second.
HIV, yes,
Virus,
HIV, CMV,
HIV,
EBV,
COVID, parvovirus, Epstein-Barr virus, and then drugs, interferon, pamidronate, sirolimus, anabolic steroids, and the others are
and lithium,
adaptive changes.
lithium.
Yes, lithium.
Okay.
And some other are adaptive changes, which includes normal kidney mass and low kidney mass. In decreased kidney mass includes the very low birth weight, unilateral kidney agenesis, and kidney dysplasias, surgical ablation, VUR, and the normal kidney mass includes hypertension, atherosclerosis, obesity, bodybuilders, cyanotic heart disease, sickle cell disease.
Yes, and preterm baby.
Preterm
adding a
baby.
sickle cell nephropathy, well, other causes of glomerular disease can cause FSGS also, like IgA can cause FSGS secondary.
Yes. Any other glomerulonephritis patient can undergo to the FSGS in a secondary form. He is very right. So I want to, can you tell me the 8 mutations that are associated with the FSGS? NPHS1, NPHS2, inverted foramen 2, alpha-actinin 4, APOL1, TRP6, LMX1B. ये सारी आपने बतानी है. You have to tell all of them. Yes. So can you tell me the 5 different variant of FSGS?
Collapsing variant, tip
Yes,
variant,
collapsing variant. Yes, collapsing variant, perihelar variant, tape variant,
Not otherwise specified,
NOS
and
variant,
classical.
and class.
and classical variant. Thank you very much. So which has best prognosis? Which has worst prognosis?
Tip has best
Collapsing as
prognosis and collapsing has worst prognosis.
Okay, 2 causes of collapsing FSGS.
Pamidronate and HIV.
Pamidronate, HIV, and APOL1. Okay. So can you tell me the acquired FSGS in bodybuilder and acquired form of FSGS, which variant will be it? In morbid obesity?
And
Perihelar variant.
perihelar.
Acquired
okay.
FSGS has always perihelar variant. So again, can you tell me what is the diagnosis here? ये भी FSGS है.
FSGS.
It is again FSGS. You can see the tough glomer capillaries are usually at one pole. ये खराब है, ठीक है ना? There is a sclerosis at one pole, so it is FSGS. So what is the diagnosis again here?
Segmental sclerosis.
Very good. So it is a segmental sclerosis. So there are different pictures on the FSGS. So thank you very much. So yes, so this is again a disease.
Mesangial hypercellularity.
Mesangial hypercellularity. ये कौन सी हो सकती है? You are right. It is
IgA.
mesangial hypercellularity. Yes.
IgA.
I want to give the 100 real cash prize to Dr. Akil on diagnosing the IgA nephropathy. Yes, it is a mesangial deposits. You can see the capillary lumens are intact and open, but the space between the capillary lumens is increased. So it is an increase in mesangial matrix, and it is actually IgA nephropathy. Thank you very much. So again, you can see here, if they gave you the both picture, so it is actually IgA nephropathy with the mesangial deposits. Okay. So I have shown the one picture that is showing the electron microscopy. You can see the red blood cells within the vessels, and you can see the basement membrane. So glomerular basement membrane and everything. So it is a one picture, and it is showing the different capillary lumen, and the in between space is the interstitium. So again, what is the differential diagnosis of this picture? I personally love this picture in nephrology.
Obliteration of capillary
Diffuse
you can see
is for mesangial capillary proliferation. Mesangial proliferation is giving it a lobular.
Yes, the capillary lumens are usually not intact, and you can see the cellularity is too much increased. So it is the endocapillary proliferation with obliteration of capillary lumen, as well as the mesangial matrix is also increased. But most of the time, it is a endocapillary proliferation is more common. And you should also see at the top, one is the proximal tubule that is usually a big lumen, and the distal tubule that is showing a smaller lumen. In transplant patient, when they give the tubules, usually they are showing the cell mediated rejection, and sometimes they are showing you the tubules and one capillary. So there is actually peritubular capillaritis. So peritubular capillaritis is actually antibody mediated rejection. So here you can see the normal anatomy. So you know that whenever there is a diffuse proliferative glomerulonephritis, so what are the differentials of diffuse proliferative glomerulonephritis?
Lupus nephritis.
Class 4. Lupus nephritis class 4.
NPGN.
Post-streptococcal GN. Yes, post-streptococcal GN. Post-infectious GN.
Immune complex low.
And the schistosoma class 2. Schistosoma class 2. Yes, class 2. Class 2. So what are the 6 classes of schistosoma? focal proliferative GN, diffuse proliferative GN, and then the MPGN with the salmonella, and then it is the then it is the FSGS, and then it is amyloidosis, and then finally it is the cryoglobulinemia. So 6 classes of schistosoma should be asked by any examiner to you. So you should be very careful. Okay.
Good.
So here it is again. Immunofluorescence picture of post-infectious GN or post-streptococcal GN. You can see the starry sky appearance. So you know that there are two patterns in post-infectious GN. One is the starry sky pattern, and another is the Garland pattern. Okay.
Guideline. Okay.
Starry sky appearance appear in which lymphoma? It occurs in the Burkitt lymphoma as well. That is a blood tumor in 8 to 14 translocation. Thank you, Dr. Sarah, for understanding this. So there are generalized lumpy, bumpy, granular, glomerular capillary walls and the mesangial deposits. Okay. So this is again electron microscopy. You can see the effaced podocyte, and there are deposits between the podocyte and between the basement membrane. So these are actually the subepithelial humps we everyday study in nephrology. So in whole nephrology, the subepithelial deposits occur in 3 conditions. One is the membranous nephropathy. Either it can be primary or secondary due to lupus or hepatitis B. Other, it is a post-streptococcal GN in which subepithelial humps occur, as well as the post-infectious GN. And third is the MPGN in which deposits start from the subendothelial space and then comes to the dense deposit disease, osmophilic changes of the basement membrane, and finally they reach the subepithelial space.
Also lupus?
Yes, lupus class 5.
Yes.
Subepithelial deposits. Okay. So here is a light microscopy and immunofluorescence. So post-streptococcal GN, it is a starry sky appearance you can see, and it is a diffuse proliferative GN. Okay. Okay. So I want to share you the next slides, please. So what is this stain?
Light microscopy, PAS stain.
PA.
Yes, PAS stain. Shaba, thank you very much. PAS stain. So what it is showing?
It is showing
Thickening of
mesangial
glomerulus.
hyperfilarity.
I don't think so.
Basement membrane seems thickened.
Yes, it is a thick basement membrane. Yes, very nice.
Oh.
So all the capillaries are intact and the mesangium is not increased, but it is actually thickness of basement membrane. And thickness, you can see, Dr. Akil, इनकी thickness बाहर वाली side पे होती है. The thickness is on the outer side, like on the subepithelial space, and the capillary lumen is very, very broadly open. Yes, very bright capillary lumen. This is the whenever you find the capillary lumen very beautiful, either it will be MPGN, either it will be membranous. ये दो चीजें होंगी बस. Whenever the picture is very beautiful, the capillary lumen is showing very beautiful in nature, there will be 2 things: either it will be membranous, either it will be MPGN. No third disease. Okay. So can you tell me the 6 mutation associated with the membranous nephropathy?
Antipilar, antibodies,
Antipilar,
thrombosporin, 7A,
NEL1,
NEL1, SEMA3B,
SEMA3B,
PCD something,
Pakta 7, PCDH7,
and Hatra,
and
HTR.
Hatra1, and what for the lupus?
Lupus
Exhaustion 1.
Exhaustion 1 and 2.
1 and 2, very nice. So thank you. So what is the first line drug for this disease? What is the first line drug for this disease? Rituximab. So we divide it into the mild, moderate, severe, and very severe form. And rituximab is also. So which trial was claiming that rituximab is superior to everyone?
Menestron 1, 2, and 3.
Sorry, brother. Menestron 1, 2, and 3.
That is for vasculitis. Sorry. That is for vasculitis.
Yes, Mentor trial.
Mentor trial. Menestron 1, 2, and 3 is for vasculitis. Okay.
Yes. So it is which stain?
Silver stain.
This is silver methamin.
It is silver stain. What it is showing?
It's rounded glomeruli. Must go properly.
It shows spikes.
Yes, It is showing the thickened basement membrane with the spikes.
Yes.
So
Yes.
it is again, yes, membranous nephropathy. So Dr. Mohammed, can you tell me what is the modified Ponticelli regimen?
What? Question again?
Modified Ponticelli regimen.
45.
Modified
Question again.
Ponticelli regimen.
I don't know.
Okay.
Not clear.
Or Dr. Sarah, can you tell me the modified Ponticelli regimen?
So in which we give the pulse steroid, we give alternative cyclophosphamide and steroids in this regime. Like on 1 month 1, 3, and 5, we give steroids alternate with the cyclophosphamide dosing.
Okay, so
You are
oral
asking about the
cyclophosphamide.
treatment?
Yes, modified Ponticelli regime is alternating cyclophosphamide with the steroid. So in the month of 1, 3rd, and 5th month,
We give it
Solo
steroid, and
you are-
1 month of 2, 4, 6, we give cyclophosphamide.
so what is the dose of cyclophosphamide?
It's a 500 mg twice weekly.
No, I don't agree because we are paying
Nay,
modified Ponticelli regimen. We are using the oral cyclophosphamide.
I am telling the whole regime. Just wait.
Ponticelli
In
regime.
Ponticelli and modified Ponticelli regime, in month 1, 3, and 5, we give steroids, and in months 2, 4, and 6, we give cyclophosphamide. For steroids, in 1, 3, and 5 months, first 3 days, we will give 1 gram methyl prednisolone for 3 days,
0.5 mg per kg.
followed by 0.5 mg per kg prednisone for next 27 days. And for cyclophosphamide, the dose is 2 to 2.5 mg per kg
Oral.
per day, oral form, for 2, 4, and 6 months.
So the oral dose is 2.5
Okay.
mg per kg per day.
2 to 2.5
Maximum we
mg
have
per
to give
kg
100
depending upon the
milligram per
voltage
day.
and everything. Yes, Dr. Sarah, can you tell me what is the treatment of membranous nephropathy post-transplant?
So it's Ritux again. We give rituximab.
No, I don't agree. So we have to
So
check.
it's written in
I
book.
don't agree with you because you should tell in a different way. Please listen. You should tell me whether proteinuria is subnephrotic or nephrotic. So if the
Okay.
proteinuria is subnephrotic, we are just increasing the dose of tacrolimus. Okay, so we are just increasing the dose of tacrolimus, and when it is actually beyond the nephrotic range, more than 3.5 gram, and it is worsening, then you should go for the rituximab.
Okay.
Okay, good.
So you should tell, just like a physician, you are at the bedside and you are treating the patient. So everything should be like a mature consultant, but not like a ordinary PG of
Okay,
first year
sir.
or second year.
Okay, sir.
You should be telling everything with a rationale. Okay, thank you. So
Sir,
what
I
is
have
this
a question.
disease?
I want to ask a
Is
question.
it linear or granular deposit?
Sir, I have
Yes,
a question.
please.
So if somebody receives, I saw a patient in the
Yes.
OPD today. There was a young patient who was known case of membranous nephropathy, PLAR positive, which was a primary nephropathy. He was initially treated with the rituximab, and he had like a partial response. He did not have a significant response with rituximab initially. Then he received, then he was given oral cyclophosphamide for 3 months. He had clinical remission. Now he presented with the relapse. So my professor was asking then how would you treat him? Currently his weight was 110 kilogram and his creatinine was around 0.9, and his proteinuria was say 6 grams, and there was a dip in the albumin as well. It was serum albumin was around 2.5. So he asked me what next option you can think about, because since he is a young adult, so we cannot repeat the cyclophosphamide again. I think creatinine was 1.7.
Yes, Dr. Sarah, you have asked. Yes, Dr. Sarah, you have asked a wonderful question. And for me, if you, I am not a specialist, but I will tell you that first option is Rituximab and the second option is the modified Ponticelli regime. So
This
because
is
he don't show any remission on the Ritux, so So detox is useless. So he was given the modified Ponticelli, and he has better outcome. But again, relapse. Now we have left with the two options. Either we can go with the CNI plus steroid, tacrolimus with the delta cartel. That is the one regime for at least 12 months.
But
The
sir, his
second up,
creatinine
because he
was
has normal
1.7.
RFTs, we can easily.
No, sir, his creatinine was 1.7.
Okay.
I just remember. That is why we got stuck.
So if the creatinine is okay, so when the creatinine is 1.7, we have newer option, the Nobility trial. You know that obinutuzumab is a newer drug
Yes, sir.
that should be
This is what.
considered in a refractory and resistant membranous nephropathy.
Yes, sir. Oh, this is what examiner was asking.
Obinutuzumab.
Yes, sir. Obinutuzumab.
प्रोफेसर यही पूछ रहा था ना, तो देखें आपका
जी
भाई भी
सर.
तो प्रोफेसर है ना. obinutuzumab,
Mashallah,
बहुत
sir.
बड़ी मेहरबानी, बड़ी
नहीं,
ज़्यादा
sir,
कहा था.
he told us that the obinutuzumab has the similar cost as
دي في
rituximab.
الكلى هنا، الكلى
Both
اللي جوه هنا.
both have similar price, so we can
بنشوفها
give obinutuzumab.
بالميكروسكوب، بتعمل اللي هي ايه، بتخلي الواحد يعمل، تخلي
Okay, obinutuzumab. So this is actually the thickened basement membrane. You can see on the electron microscopy. So it is again showing the effacement of Ford process. So here usually there is 500 to 600 angstrom or micrometer. I don't know the exact unit. So this is membranous nephropathy. And there are that can be idiopathic and that can be secondary membranous. So Dr. Akil, can you tell me the difference between primary membranous versus secondary membranous?
Okay, in primary membranous, usually we find granular IgG4, fine granular IgG4 deposits, while in secondary membranous, we find the IgG1, IgG2, and IgG. And also regarding the antibodies for the primary membranous, we have regarding the antigens, we have the PLF2 or antigens for the thrombospondin type 1 domain containing 7A, then NEL1 and SEMA 3B, and the PAGDA and the HARTRA. And for the
Yes,
second,
80% patient have antipolar positive. So
ah,
you should tell me that in primary membranous nephropathy, is a severe disease that can be idiopathic, and secondary membranous nephropathy has usually some causes that can be hepatitis B, that can be graft versus host disease, that can be sarcoidosis, that can be IgG4 related disease, that can be rheumatoid arthritis, that can be drugs like penicillamine, busilamine, and gold as well. So you have told very right. So secondary disease is actually a less or lighter disease as compared to the primary disease. So what is the most common cause of secondary membranous nephropathy?
lupus nephritis.
Lupus nephritis class 5. The answer is good. So here it is again. It is written here. So these are again. Yes, Dr. Izzat Abdal, you are very right, brother. So again, you can see here the glomerular basement membrane is looking very beautiful when the gloom is looking very beautiful. Either it will be membranous, either it will be MPGN. So here it is a clear-cut double tram track appearance. So what are the DD of double track? Yes, Dr. Sarah.
Sir, it's MPGN, membranopropathic
MPGN,
GN, transplant glomerulopathy,
transplant
and
glomerulopathy, MPGN,
and
chronic antibody-mediated rejection.
chronic. Yes. Sir, वो तो
Okay.
फिर
So tell me the modern classification of MPGN.
One is the immune complex mediated MPGN, and the second is the complement mediated MPGN.
Sir, it has four classes basically, but one is the immune complement mediated, and the other is complement mediated, and the third is non-immune, non-complement mediated, and fourth is idiopathic.
Okay. So listen, please. So what are the six causes of non-complement, non-immune type of MPGN?
It's healing phase of TTP-HUS, EPLA,
Okay.
radiation nephritis, and it also
Cohen syndrome.
includes the drugs.
Cohen syndrome, radiation nephritis,
Yes, sir.
and six drugs.
Drug-induced TMA, sickle cell anemia, Cohen syndrome. Other is prothrombic state,
Malignant hypertension.
fibrinogenemia, and transplant
Yes,
glomerulopathy.
malignant hypertension, and some drugs that can be CNI, that can be ticlopidine, that can be gemcitabine, that can be bevacizumab, and that can be quetiapine, that can be oral contraceptive pill, that can be mitomycin C, that can be interferon.
All these causes, all these are the causes of TMA.
TMA and all these causes non-immune, non-complement mediated.
Okay, sir. So we have to remember the causes of TMA.
Okay, so what are the immune immune mediated causes of MPGN?
Sir, it includes the infections. It can be viral infection, hepatitis B, C, bacterial endocarditis, shunt, ventriculoperitoneal shunt, visceral abscess, leprosy, meningococcal, yes, Coxsackie virus, protozoa infections, malaria, mycoplasma,
Number one,
leishmaniasis.
infections. Number two,
second is immune complex
monoclonal
mediated
gammopathies.
autoimmune. Yes, sir.
Autoimmune, and number three, monoclonal gammopathies. So we will study in detail every topic, but can you tell me what is the diagnosis here? बहुत मुश्किल सवाल है ये.
Sir, this is it hyalinosis? which ऊपर red है.
Yes, in slide
double
A,
contour of
there is GTM technique.
yes, there is
double
a thickening
contouring.
and double contour. Yes.
Double contouring. It is MPGN. Okay, so it is IgG positive. So there are viral as well as bacterial deposits. So viral infection have IgM more dominant, and bacterial infection have IgG dominant.
IgG.
Okay. So what is this diagnosis? MPGN again. Which strain it is used? Which strain it is?
Upper is silver methamine.
Silver. Very good. And the second is immunofluorescence, and third one is the electron microscopy. So what it is showing here again? Double contouring.
It is double contouring.
Double contouring.
Okay. So here you can see the MPGN pattern, granular as well as segmental contour capillary. So what is the diagnosis here?
Sir, this is crescent.
Very nice.
Formation.
It is actually RPGN and crescent. So 10 causes of RPGN.
ANCA, anti-GBM.
ANCA vasculitis, anti-GBM disease, right?
And IgA.
IgA nephropathy in 5% cases, lupus class 4 with crescent.
And sir, vasculitis are the immune complex mediated lupus, MPGN, and endocarditis.
And fibrillary GN. Fibrillary GN also lead to the RPGN picture. Okay.
And
so
rarely membranous.
Rarely membranous and cryo as well. Cryoglobulinemia. So what are these? ये कौन सा stain है? Which stain it is? It is a magenta. So it is PAS, and it is again showing the crescents. So here you can see, I have make clear it for you. So here you can see the crescent actually, what crescent is. Okay. So these are actually crescents.
So it's a crescent which is compressing the globe capillary tuft.
Yes, it. So this is the reason that patient become anuric here. So what is this?
Interstitial
inflammation and the crescent as well. Crescent as well as the severe interstitial inflammation. So severe interstitial inflammation occur in the acute interstitial nephritis, chronic interstitial nephritis, Balkan endemic nephropathy, aristoleucic acid nephropathy, IgG4 related disease, as well as cell mediated rejection.
Okay.
And sarcoidosis.
Cell mediated.
Sarcoidosis. Okay. So the tubules are back to back, so it is not ATN. Okay. So what is this?
This is a necrotic fiber.
Crescent.
Crescent hai, acha.
Okay. It is crescent again.
Sometimes it's very difficult to.
So I am just concluding my today lecture. So thank you, Dr. Mohammed, and Dr. Saira, Dr. Akil, Dr. Izzat Abdilal, and Dr. Khashia, and Dr. Laila, and everyone. So again, H&E stain is reserved for it is usually basic stain of histopathology. It is telling about the cells, the nuclei that are looking blue or darker. So it can show the inflammation and architecture. So PAS stain actually showing the magenta color, and it is the best stain. I will pick one of them. So in nephrology, I am incomplete without this PAS stain. So I am in love with this PAS stain. So it is just like just like a CT with contrast or MRI with contrast. So H&E stain with the contrast is actually a PAS stain. So GBM and T, you know that disease that is Jones silver stain, blackish appearance, GBM architecture for best for membranous, best for MPGN and mesenteric for the fibrosis, and as well as when you have severe hypertension like malignant hypertension and a scleroderma or sickle cell crisis or renal artery stenosis, you can see the changes in that vessel with the mesenteric stain. Congo red is reserved for amyloid, and amyloid. So second stain for amyloid is thioflavine, and first one is the Congo red, and the light show the apple green birefringence. And Prussian blue is for iron. You know, we have one disease with iron overload, that is hemochromatosis, that is causing Fanconi syndrome and affecting the proximal convoluted tubule, leading to glucoseuria, proteinuria, amino acid uria, and difficult other as well as different presentation. So the stain that we are using for the copper is the for copper it is actually acid stain, and the disease for
Rubinic.
that is leading to the rubinic acid stain for the Wilson disease. And you know, for uh, so I'll for you know that eosinophil, it is actually Hensel and Wright stain, HANSEL, Hensel and Wright stain. So you should be aware of all these stain. So today lecture is concluded. Thank you very much for joining us and sharing the wonderful information with me. So I am learning from you and you are learning from me. So it is a mutual knowledge sharing. Thank you very much. Allah Hafiz.